Today we will be discussing upon the most important aspect of the orthopedics, which includes almost like the 50% of the practice, which is the knee pain. Knee pain, which predominantly can be classified into two groups. Let's say the young people presenting with the knee pain and the older people coming with the knee pain. These are two broad classifications. We will like to discuss each of them separately. If we look at the younger patient first, now we see a lot of people coming with the age of maybe 25, 30, 35, which we never used to get, coming with the complaints in the knee pain, and they do come with most of them the complaint being the pain. We have to evaluate these patients for all possible kind of reasons. The evaluation will of course include clinical assessment, which would be like the most important aspect, which has to be supplemented by the radiological diagnosis. If we look at the broad reasons, the reasons will come down to the meniscal lesions, to the cartilage issues of the knee, the alignment issues of the knee being varus or the valgus. At times we see a difficulty with the patellofemoral joint, which predominantly presents in the anterior knee pain, which so often most of us will complain the pain in the knee, especially going up the stairs. We do come across the symptoms like the patella going off the track, symptoms of catching and locking with the loose bodies, and of course the symptoms of instability with ACL, PCL and the other collateral ligaments getting damaged. Most of the time these are traumatic injuries. As I have already mentioned, the evaluation is mostly clinical, which has to be supplemented with radiological investigations like X-ray and the MRI. I suggest Dr. Vinay to please take over for the MRI aspect of the knee, which he will be elaborating what to see in the MRI.
Good evening everyone. As we all know, the MR is the only modality for the detailed evaluation of cartilage, ligament, tendon and meniscus, including bone marrow edema, contusion, osteonecrosis and so on. So coming to routine protocols that we follow, we do T1, T2 sections in the sagittal coronal plane, GRE star images and PD head set images in the sagittal and coronal images, which is most useful in evaluation of meniscus, and 3D sequence like dash sequences for the evaluation of cartilages. Coming to the normal anatomy of the knee joint, this is here we can see the anterior cruciate ligament and posterior cruciate ligament, patellar tendon on the PDs, on the sagittal images of the knee joint. This is the kind of MRI machine that we have with 3 Tesla Siemens MRI steam plus dot scanner. We get this sort of anatomical detail which we never seen before. We can see the anterior cruciate ligament. This is nice, thick, hypointense vein, and we can see the meniscus so nicely. This is hypointense on all the sequences. And coming to the evaluation of the planes, the menisci are generally best studied on sagittal and coronal, and PDFS images is best for evaluation of menisci. And similarly, evaluation of cruciate ligament, sagittal is most useful sequences, and for the evaluation of collateral ligament, the PDFS coronal image is most helpful. Coming to the evaluation of cartilage imaging, we all know for cartilage damage occurred by taking of the water, and it is a compositional rather than quantitative measures. And earlier detection of chondromalacia and osteoarthritis help in prevention of progression of the osteoarthritis and best in the course of treatment administration. This is the kind of image that we get on 3D MRI imaging. We see the sagittal MRI of the knee joint. We can see how nicely demonstrates of the cartilage for the tibia as well as the fibula. This thickness and this beautiful demonstration of cartilage we never get on 1.5 Tesla and loads strength MRI.
And it is very pertinent to mention here that the cartilage, which is such a common entity nowadays under question, is so beautifully seen on the MRI, and this continuity, let's say if we find a break here in the weight bearing area, has a lot of clinical significance, which is so beautifully seen here and gives us a lot of confidence that yes, what are we dealing with exactly.
Confidence for the radiologist as well as for the treating orthopedist. Now this is the PDFS sagittal images of the knee joint, nicely demonstrating the patellar cartilage. You can see the entire thickness of the patellar cartilage.
Again, one of the important aspects which must be looked up to, because nowadays we see so many young people coming with the anterior knee pain where this patellofemoral cartilage has to be evaluated.
Now this is how the meniscus look on sagittal and sagittal imaging. This is the coronal imaging showing the meniscus. You can see both the meniscus on the PDFS coronal imaging. Now coming to the normal menisci, there is no normal body appearance, and the posterior horn of medial meniscus is always larger than the anterior horn, and they appear dark on all the surfaces. The posterior horn of meniscus cover the articular surface of the tibia. Now coming to the meniscal injury, they are rated into grade 1 to 3. Grade 1 is the globular signal which is not extending up to the articular surface, and grade 2 is the linear hyperintense signal not extending up to the articular surface, whereas in grade 3 signal, in grade 3 there we get signal which is extending all the way up to the articular surface. Now this is the graphic demonstration of the grade 1 signal, which is a globular signal not extending up to the articular surface. Again grade 2 signal which is a linear hyperintense signal not extending up to the articular surface. This is the grade 3 signal which is extending up to the articular surface. Now going to the various type of